talk about regarding 412 monkeys as a fictional case study? There's no wrong answer.
Sounds like the main character could make the argument that his schizophrenia because he has both. Well, auditory hallucinations, definitely. You can say like, oh, this time travel is not real. That's a visual hallucination as well.
And I think we would have to assume that. I mean, if is it James Cole presented to clinical attention, and anybody here on call this weekend?
Oh, I am.
All right, so if you're on call, and I'm not on call, but hypothetically, if you called me and gave me this quick HPI, and I asked you, which I inevitably would, what do you think is going on? I would hope that you wouldn't say, well, it's obviously a time travel fabrication. So I think it's reasonable to assume that we're going to look at his belief in time travel as a delusion. I mean, it might be an obsession, but in asking James, do you really believe you're able to time travel? I suggest that he's going to say yes, and it's going to be fixed. Right? So, again, I think it's a reasonable assumption for a clinician that it is not bound in reality. And once you have an idea, a thought, that isn't bound in reality and is without insight, fixed, then you're dealing with a delusion. So, auditory hallucinations, delusions. So we think he has a psychotic process going on. All right. We talked about this morning with Joe DeVola. What illnesses must we examine as a clinician, work up, and rule out in order to continue with schizophrenia as our provisional diagnosis? There are 5.
Substance abuse?
Good. So substance-induced psychotic disorder. 4 more.
No other medical conditions.
Good. So a psychotic disorder due to another medical condition. 3 more.
Schizoaffective?
2 more. On a roll.
MDD with psychotic patients.
So primary mood disorder. Good.
I guess you can clarify the timing, like is it schizophrenic or if it's only.
We definitely have to do that, but not before we rule out all 5 disorders, including an autism spectrum disorder. All right, so let's start off with the easy one. Is 12 Monkeys a fictional case of autism spectrum? And I think the easiest question to address this is to ask, well, is there any evidence of an autism spectrum in Cole's history? And the answer here would be A, yes, B, no, C. It doesn't even matter. Any guesses? I'll stress guesses. A, B, or C? Yell it out.
I'll say no.
No.
No? No? Who else?
I'm gonna go against and say yes.
Yes?
Yeah.
So anybody want to say C?
Let's see.
Doesn't matter.
Ah.
It's C, doesn't even matter. We have to remember that the reason why the American Psychiatric Association included autism spectrum in evaluating for schizophrenia is because the characteristic deficits of communication and behavior overlap with positive symptoms of schizophrenia. So it's unfair, unethical, to have someone who at the age of 8 had severe autism, and then when they're 18 and come to your clinical attention say, wait a minute, there's disorganized behavior, there's disorganized thought process, you have schizophrenia. That's not true. However, individuals with autism spectrum can develop schizophrenia like anybody can develop schizophrenia. And if they develop delusions or hallucinations, that would not be explained by their pre-existing condition called autism spectrum disorder. And in Cole's case, we already said he has both. So it doesn't matter. It doesn't matter if the prequel to the 12 Monkeys, or even 12 Monkeys itself with time travel back to when Cole was younger, establishes an ASD. his delusions and hallucinations allow for us to continue to discuss schizophrenia as a single best diagnosis. Is there an active mood component with regard to Cole's presentation? If your answer is no, then both schizoaffective disorder as well as a primary disorder with psychotic features are both ruled out.
I don't think so. I didn't see any strong evidence of a persistent mood disorder in the film.
Anybody beg to differ? Anybody want to keep these two in the differential? Consensus is that we're good, we're comfortable in saying no?
We're good.
We're good, all right. Number 3. Is there any evidence in the film, if you read the script verbatim, that substances are playing an active role in Cole's presentation? Yes or no? Do we see him smoking dope? Do we see him shooting heroin? Do we see him using any substances? Is there any allusion to substance use in this movie for this character?
I guess like non-intentional substance use. And this could just be like an issue of semantics or interpretation. So when he's being interrogated and they're like, they made me take drugs, but we don't actually see him taking like street drugs, like, you know, that we would automatically assume. But that's what the interrogators are like assuming. So,
Does he get the answer to that question?
does he, I'm sorry.
If they're interrogating him,
Uh-huh.
does he provide an answer?
Oh, he didn't.
He didn't, okay. Well, even if we were to say that there's nothing discrete in this movie, in the script, that would allow us to say that drug use is a core feature to his character, the follow-up question is, should the overt lack of evidence, if that makes sense, reassure us that therefore this movie isn't about drug abuse? And the answer should always be no. Because as a clinician, we always have to maintain a high clinical index of suspicion, period. Right? Always. When the patient tells us no, if he actually said no, wouldn't matter. We're going to keep it in anyway. Right? And I think the fact that the interrogator brought it up, and the patient didn't provide an answer, that's even a little bit more concerning. Right? So let's keep it in. And we're going to apply the same principle to an underlying medical condition. Is there any evidence in this movie that Cole has an underlying medical condition that might be demonstrating or manifesting as psychosis? So again, the hesitancy is going to, I read as a no. Again, it's not overtly obvious in the movie. It's not written in the script. Same question. Does the absence of that reassure us that therefore this film isn't about psychosis due to an underlying medical condition? The answer is no. Again, I see you shaking your head, but now we can even quantify it. How strong do you feel that it should be included? That is, how high the differential should it be? And the answer has everything to do with your evaluation of 2 risk factors. Right? Is the person male? Are they older? Because on shelf exams, again, it's the focus I want today. On shelf exams, if you get a clean bill of health with regard to the absence of information, the question writer on your shelf doesn't say anything about abnormal labs. They don't say anything about a past medical history. Can you assume health? And if your patient is older and male, absolutely not. Of course, the opposite is also true, because the opposites are protective variables or factors. If they're younger and female, you can assume health. Unfortunately, Cole's character is not young, and they are not female.
Can I just ask a question about the young and female? Because I know a lot of the autoimmune diseases can present with psychosis, like lupus, cerebritis, and things. So even if they don't mention anything, can you just assume the young female doesn't have an autoimmune process going on, or?
So the answer is yes, but there are outliers.
Okay.
Right? Autoimmune would be one. The other one would be cardiac arrhythmia, SVT. Those are the 2 outliers that appear on shelf exams. Let's go pick up. And then there's 2 intermediates. If they're younger male, if they're older female, they're going to be mid-level on your differential. But that's how I would quantify it. And I think that is consistent with the way the test questions are written on your shelf. All right, so here we are with regard to coal. The final step in your case formulating what the most likely diagnosis is, main character 12 monkeys, is if you could look at your notes page in terms of those notes you took while you were watching this movie, and now cross off everything on that page that would be explained by everything we just discussed. Cross off schizophrenia and schizophrenia-related symptoms or those due to a medical condition, substance-induced. Would there be anything left on your note page? Because if the answer is no, then we fully explained everything we observed, everything the patient told us. If if your notes page still contains information, we have more work to do. So, how comfortable are you right now saying we're done? At least with this character.
Be a little suspicious.
And here, I will allow you to take some creative liberty.
I guess something else we could consider is him having these nightmares, like the recurrent intrusive nightmares, so you might want to keep and some sort of PTSD on different.
I think so. Yeah, I think he has recurrent nightmares, and I think that he has flashbacks. And I don't know if I'd be comfortable saying, well, we could easily attribute that to schizophrenia, maybe a substance, or maybe even an underlying medical condition that we have not yet found. I don't think that would actually be correct. On the other hand, we know, spoiler alert, the way this movie ends is that he does observe and witness a traumatic event. Again, that's the creative liberty we have to take. So that certainly would support a working diagnosis of post-traumatic stress disorder. So with regard to PTSD, I'm wondering now if PTSD would make sense of any of those other symptoms that we originally attributed to schizophrenia. I mean, could PTSD explain his auditory hallucinations? The answer is yes. Individuals with post-traumatic stress disorder often have intrusive thoughts. Intrusive thoughts are in fact a diagnostic criteria. And those intrusive thoughts might be so severe that they may present looking very much like auditory hallucinations. One of the questions we usually ask our patients to try to see or gain a perspective of their level of insight is asking, are these your own thoughts and a product of your mind, or are they coming from outside of your head? Because if the individual maintains enough insight to answer that question, no, they're my own thoughts. I mean, I can't control them. They may or may not use the word intrusive. But that level of insight allows for us to realize these are intrusive thoughts and not auditory hallucinations. If the individual does not have insight and experiences their very own thoughts as coming from outside of their head, they're going to present as auditory hallucinations. So we have to get the patient's perspective with regard to insight. What might Cole say? Any you've got as to what answer he would provide?
Outside of his.
You think you'd say they're coming from outside of my head?
Because it's the voice of that homeless guy, right? So I feel like if you were your own thoughts, then it would be at least your own voice.
And we do ask that, right? Sometimes, I mean, beyond asking, are these your own thoughts, or are they coming from outside your head? Do you recognize the voice? Because sometimes people will, even though they'll say no, they're not of my mind now. They're not a product of my own mind. They're coming from outside of my head. Do you recognize the voice? Yeah, it's me. It sounds like me. And so we kind of probe again by asking if they're familiar or if the voice sounds familiar to them. And sometimes they'll say that it does. Sometimes, of course, they could say that it doesn't. This is all speculative. I don't know what Cole will say, but I tend to agree with you. If I had to guess, probably outside of a second. So, again, a little diagnostic conundrum here. We also think that he's delusional. He's paranoid. Could that be satisfied by a DSM criteria for PTSD? Hypervigilance. Hypervigilance is a criterion for PTSD that, again, may present looking like paranoia. So, not clear right now. Now, the other part of this is that we're kind of discussing this as a dichotomy, that it could be one or the other. And certainly, if we continue to kind of think in that categorical type of way, we can say, well, yes, both. But we could also conceptualize this a little different and respect that these different categories are artificial. And that people may actually demonstrate both because there really isn't such thing as PTSD compartmentally versus auditory hallucinations in the context of schizophrenia. That, we're talking about neurobiology, and who cares what we label it? And that in part is true. That whether we call it PTSD driven or whether we call it due to schizophrenia, he's likely struggling with dopamine in the central nervous system. And certainly during times of stress, and it looks like this individual is under significant stress, what might be hypervigilance today may become paranoia within an hour. What might be an intrusive thought right now, after lunch, could be an auditory hallucination. And so stress can result in poor insight or worsening insight, and therefore a change in the vocabulary we use to label these findings. What do you think is going to help him most? Because if we think we're going to go towards our antipsychotic, we're going to probably treatment plan by using the term schizophrenia. Whereas if we think that this could be actually addressed in the therapeutic session, maybe with an SSRI, then we're probably going to say it's PTSD in our treatment plan. Any thoughts here?
I asked thoughts on what his treatment plan is going to be exactly per se, or which treatment plan you agree with?
Yeah, I mean, do you think your first prescription is going to be for an antipsychotic or an SSRI in this patient?
SSRI and psychotherapy.
So you might be more consistent with a post-traumatic stress disorder if you want to start an SSRI. I guess there's no wrong answer. And by the way, when severe PTSD presents, clinicians have co-prescribed the SSRI with the antipsychotic. So again, we treat the neurobiology, and what clinical term we come up with to describe that, sometimes is a coin flip. And we don't want to get too overly focused on these artificial categories the American Psychiatric Association created for us. They're important because it's the way doctors communicate to each other through the medical record. But we shouldn't let that kind of divert our attention away from the other important concept of this, and that's the neurobiology area. He has excess dopamine. Now, we can go with SSRI, certainly, and not only can it help the anxiety, we think that it's truly a primary anxiety disorder called post-traumatic stress disorder, but maybe one that actually has agonistic properties at the 5-H2 receptor, because that will slam the brakes on dopamine too. Right? So it's something to look for. So call your friendly neighborhood pharmacist and ask which SSRI has the highest potential, or which one is most potent with regard to 5-HT subtype 2 agonism. I don't know offhand. We could easily look that up, but that would be my choice of SSRI here. And again, practicing conservatively, if we think we have time and our patient's safe, which he may not be, we can let the SSRI take effect. We're thinking at least 4 weeks. And if we see a change, we see an improvement in functioning, wonderful, but if not, maybe it is time to add on that antipsychotic, if you're not gonna do it day one. So, different ways to go around treating here. Any other thoughts about Cole? Any other characters in 12 Monkeys you want to discuss? By the way, for Cole, before we close the book on this case, wasn't there a diagnosis that somebody provided him in the movie script? Or was it Brad Pitt's character?
No, it was his character.
It was his character, right? Do you remember what it was?
Schizophrenia.
Schizophrenia. So we're not too far off. Okay. Although I think, again, the writer-director probably would have been wise to include your observation that PTSD should be in the differential. Maybe he didn't include it, or maybe they didn't include it, because by doing so, the informed viewer would have said, well, we're going to probably see a traumatic event then, and it may have given away the end of this movie. So maybe that's the reason why they left it off. Doubt it, but maybe. Brad Pitt's character.
I was gonna say, we can talk about Jeffrey.
What was his name in the movie?
Jeffrey.
Jeffrey? What's going on with this guy?
Delusional.
Delusional? So we think he's got a psychotic process?
Yes.
What's his fixed belief?
Sorry, I called it delusional.
Sure, honestly, it seems like it kind of goes with a plan that's, or an idea that's planted in his head. So, and it doesn't seem fixed, he's just sort of acting according to whatever information he gets.
He wanted to, like, he wanted to kill all humans, kill humanity.
That wasn't him though, it turned out to be, a twist at the end, but that wasn't him.
That's what we led to believe.
What did I say? What caught your eye on this character?
I think at times he seemed almost manic.
Yeah.
And what supports a diagnosis of mania?
I guess he would have, I would consider him to have like irritable mood, seem consistently irritable, seem to have very high energy, a little bit of like delusions of grandeur, that he could deliver for all the animals and save the earth. So like he's sharing a lot of his like big past. He smoked kind of quickly.
Yeah.
Yeah, I think we're probably flight of ideas and rapid speech. Any evidence of inattention?
Yeah, I feel like he kind of just flitted around from one idea to the next.
Yep. So we're going to talk about bipolar and related disorders in the context of Jeffrey. But it looks as if we have some signs and symptoms of overt and active mania. If we think that his grandiosity, do we think, well, let me ask it in the form of a question. Do we think that his grandiosity is in the form of an elevated or expansive mood? And I'm only asking because I need to know the number of criteria we need to meet, because if it's irritable, we need to meet one additional criteria, right? Possibly. I mean, even if we were conservative and said, no, it's only irritable, I still think he meets the number of criteria necessary, but 5 total, given what you just described. So what might we have to rule out now in order to further rule in a manic episode in Jeffrey?
Substances.
Yeah. So is there any overt evidence that Jeffrey is using substances? Similar question. Any overt evidence that Jeffrey's apparent mania is due to an underlying medical condition? No. Again, we always conservatively keep it our differential nonetheless. He is younger, but he is male, so he's got intermediate risk with regard to an underlying medical condition that has not yet been diagnosed. So we'll leave it under differential, and we always leave drugs in our differential. Unfortunately, if his urine drug screen came back positive, we have to really tease away the chicken and the egg, because bipolar has the highest comorbidity of substance use disorder, 60%, 60, which is the highest of any established mental disorder. So evidence of a co-occurring mental disorder may just be that, maybe co-occurring, it may not be etiological. So we have to establish timeframes if there is evidence of a substance use disorder, which there might be. The final step here is really one other condition that we have to consider. That is, if a person has a manic episode, they're always bipolar 1, with one rare exception. I mean, rare literally meaning less than 1% of the US population, which is the only illness in the DSM that a person may be manic and is not diagnosed with bipolar 1. No. Schizoaffective disorder, bipolar type. It's the only time. The only condition, only mental disorder. So we'd have to definitely investigate that. And the clinician then we don't have the evidence in this movie, right? It's a slice of time, slice of times plural, but we don't get enough information to establish discrete timeframes to address that question. In one case, and this applies to schizoaffective disorder versus a primary mood disorder in general. Schizoaffective disorder, the individual in a slice of time, AKA office interview, is going to present with co-occurring mood and psychotic symptoms. The evaluation of which will reveal a past history of psychosis absent mood symptoms. That's schizoaffective. The primary mood disorder with psychotic features, that includes both major depression as well as bipolar, will present exactly the same. The past history, in this case, will reveal that there are mood symptoms minus psychotic symptoms. So at some point in history, you're going to see one without the other exposing and revealing what the primary issue is. If somebody had come in, we'll call him Jeffrey, and he does turn out to be bipolar with psychotic features, where in the current episode are you most likely to find the mood symptoms absent the psychotic symptoms? So let me take that one more time. Let's have a patient hypothetically present to you in clinical practice with co-occurring mood and psychotic symptoms for which he has bipolar 1. For the current mood episode, where should the clinician investigate to reveal mood symptoms absent the psychotic symptoms?
Onset of the episode?
Okay.
At the onset?
Okay, exactly right. At the beginning, at the onset. The same does not hold true for schizoaffective. Right, so if I ever ask that same exact question for an established schizoaffective case, the answer would not be at the onset of the current episode. It could be anywhere, with the 2-week window being required. That is a 2-week window in which the mood symptoms are absent, but the psychotic symptoms persist. It may occur in the beginning of the episode, but it doesn't have to. And more likely than not, it does not, does it? All right, so again, that's just a clinical pearl in terms of where actually to focus your clinical attention and establishing timeframes. Not necessarily for the HPI, the last couple of days, couple of weeks, but the current mood episode, no matter how long it is. For mania, it could be 3 months. For depression, it could be 6 months. For schizophrenia, schizoaffective, it's going to be longer than 6 months. So you gotta trace it back. Any other thoughts about Jeffrey? Any other observation in this movie pertaining to this character that actually might be consistent with this being bipolar? I think, well, let me derail you just a little bit. If you were to ask a non-white coat person about Jeffrey's character, what might one of their observations be to the average moviegoer? Yeah, I didn't see this movie. Explain to me what this character does. I want to know about this character. I want to build a mental image in my head. Talk to me about this character.
Well, he's institutionalized psych-hospital.
So we know he has a past psychiatric history significant for prior inpatient psychiatric hospitalizations. Okay, keep on going. His behavior was described to me already. Keep on going.
I don't want to just give him a random answer because I'm trying to see how to describe this in very layman terms, other than say he's awful.
And he comes from a prominent background.
What?
His dad is like a big shot scientist.
His dad is a big shot scientist who he obviously gets along very well with in a very nurturing, loving way.
No.
No. More about that?
Difficult home life situation?
I mean, clearly there's something going on here with dad and son. You know, and not that this always occurs, far from it. But when you hear this, especially in a fictional movie, it does serve as I think, a door to just probe that the onset of the mental disorder may have been at a young age. It may have been at a young age, and boy, is that consistent with bipolar. Not every person who has the onset of bipolar in their teens winds up having such an adversarial relationship with their parents. Not saying that. But in a case where that relationship pushes the narrative forward in a fictional movie, a movie that we define or we recognize a character as potentially having bipolar, it's consistent. We at the very least as clinicians would have to go back. Talk to me more about your dad. When did this start? Because for bipolar illness, the average onset is younger than 20 years of age. And that's a full decade before major depressive disorder, if you're trying to delineate one mood disorder from the next. And the way, not necessarily depicted in this film per se, but the way in which this usually presents, shelf exams and clinical practice, is that a person comes in with a chief complaint of depression at the age of 15, for which you reveal 5 or more symptoms from CABs. After you do the extensive evaluation, including a differential diagnosis, you diagnose a major depressive episode. Your concern here would be whether or not they have major depressive disorder, or whether, because of their age, it's more likely to be a major depressive episode as part of a bipolar disorder. What do you do? And the answer is not prescribe Prozac and say follow up in 4 weeks. This happens. You believe the current mood episode is clinically significant and requires medication. You do not think psychotherapy alone is appropriate. You also don't believe that the patient is in imminent danger to themselves, and therefore you feel comfortable with medication management in the outpatient setting. "15 years old, rules in for city caps. No suicidal thoughts. The safety assessment is that they are not imminent danger to themselves or others, and there are only mild risks for self-harm." It's an outpatient follow-up. What do you do?
Did I miss this? The teenager goes in for city cops. Do they also have manic episodes or symptoms or no?
They, nope.
No.
Not current. Your psychological or psychiatric review of systems, negative for any median.
Okay.
And the past history reveals no prior episodes of mania. But doc, I'm concerned that my son or my daughter is only 15 years of age. Can't this be the way bipolar presents? The answer is yes. Because bipolar usually presents with depression in both males and females. So doc, how do you know? Next words out of your mouth. That's right. That's exactly what you tell them. You be honest. You don't know. Now what do you do? What do you want to know?
I don't want to say test the waters.
So we don't know. This could very well be the initial presentation. The odds are that it's not, but it very well may be. So let's look at these odds a little bit and see if we can put a little bit more sense to it. Are there any people in your family who are afflicted with bipolar affective disorder? And I certainly want to know about first-degree relatives. Right? If the answer is no, it's reassuring. And that would be certainly first and foremost on my mind. And with that major risk factor removed, what we can do is prescribe you a medication that we know is approved for the treatment of the depressive episode. However, if this depressive episode does turn out to be part of a larger disorder called bipolar, it may initiate mania. So at this point, let's review those signs and symptoms. And at the earliest warning sign, contact me, 911, or your local screening center immediately. And that's the way to proceed.
What
You don't know.
happens if the patient does have a strong family history of bipolar? And would you then start a mood stabilizer?
So here's the other issue. And this all depends on what type of physician you are, giving your patient autonomy to make an informed decision, and then providing them the scenarios. Because if a first-degree relative, and at this point, let's just say only one first-degree relative who was not a monozygotic twin, has bipolar 1. We can either provide that antidepressant therapy with the risk now being higher than it was just a minute ago, with the same treatment plan. Let's review the signs and symptoms of mania, and let me provide you access numbers. All right. And I certainly want to talk about social support, what is the people, who's the person living with, etc. On the other hand, we could prescribe a mood stabilizer. And if we're wrong, again, if this is a false positive, then number one, that mood stabilizer is not likely to help, so your current condition is likely to worsen, which ultimately could include suicidal thoughts. And you'll be exposed to side effects from a medication that you quite frankly didn't need. Those side effects include blank, lithium, sulfuric acid, or if it's antipsychotic, all those medications have major side effects. Which scenario do you prefer? Allow your patient, now unfortunately the patient's 15, so allow the patient and their parents, their caregivers, to make an informed decision. And so that's the way you would proceed here. What's the one other option here? So let's actually carry this. Let's play this out. Let's say you go with scenario A. Provide the medication. Which medication? So we just put a name to it. You want to prescribe today for what you are now calling a major depressive episode, and prescribing an antidepressant. So we're going with scenario A here. I mean, shut my mouth. Sertraline, right? And the good news here is that what he knew is that you can shout out any antidepressant, you'd be right, because all antidepressants are equally effective. So you know, sertraline. So sertraline, 25 milligrams. Want to see them back how long?
Like 6 weeks.
6 weeks? Anybody want to see them back any sooner? Huh?
I'd say 4 weeks.
4 weeks? 4 weeks, fine. All right, 4 weeks later, they don't show up. You get a call from the medical examiner. Unfortunately, they're deceased, and the cause of death is deemed a suicide. You hang up that phone. Now, I'm going to ask this question, not because it's a question that you must ask because you want to save yourself in your practice per se, but I'm going to ask this question to continue a conversation as a teaching didactic. Are you liable?
I want to say yes, but I hope not.
Now, I will tell you that between your office visit and the time of death, there were 0 manic symptoms. So it isn't like you made the wrong choice. This person did not become manic and in a manic state leap from a building or fall take a fly or anything like that. 0 evidence of mania. Are you liable?
Did you, like, could it depend on documentation? Like, if you saw the patient, they actually denied SI, and then you documented, patient does not deny SI, is not, or patient does deny SI, is not an endanger to self. So, if you, like, have that documented, are you not liable?
So what is documented, great point, is you did perform a standard and routine mental status exam within which you assess for thought contact, within which you assess for any suicidal or homicidal ideation for that matter, and you did in fact document no SI, no HI. It's there. Are you liable now?
I don't think so. I think you also have to say, I think all SSRIs have a black box warning, as long as you told the patient, you know, what the risk benefits are, and to also, I mean, again, like to say, once we start this medication, there is this risk if you feel any SR, you know, contact me immediately, then I think that's further covering.
So informed consent to take the SSRI, including the risks, benefits too, but the risks including suicidal thoughts. You did in fact, in prescribing this medication, discuss with your patient and document those risks. That includes those that are short-lived and transient, anxiety, insomnia, headache, as well as those that might be more severe and persistent, suicidal thoughts. By the way, the other ones that could be more persistent include not only suicidal thoughts, but also weight gain and sexual dysfunction. Those are the big 3. All 3 were discussed with your patient, and all 3 are in fact in the clinical record documentation. Good job. You liable now? Pretty good, right? It's good. You're still liable. And the hint here is that you're liable for the same exact reasons that if you left it like this on your OSCE, you would fail. Dr. Deo would fail you. That's their hint. What?
Any firearms at home?
Good. All right. So even though you inquired about suicidal thoughts, that is only the first question of your safety assessment. If you ask or inquire about suicidal ideation, but don't ask about an active or organized plan, imminence, or access to firearms, you fail. I think you alluded to that, but I didn't hear any specifics.
So even if the patient says, no, I don't have any SI, you still have to ask if you have a plan about killing yourself, you have.
100% of the time. And the awkwardness is usually sidestepped when, after they say no to SI, you say that there are 4 total questions that you must ask for a comprehensive assessment for your safety. So bear with me. Let me just ask these 4 questions to make sure you're safe. And then when you ask about a plan, patients usually don't look at you weird and say, I just told you I don't have any thoughts. How can I have a plan? If you don't reframe and you ask about a plan immediately after, they might look at you like you're a little weird, and rightfully so. But in this case, you did that, you reframed, you asked all the suicide questions, quote unquote, the safety assessment. And they said no to SI and HI, an organized plan. Imminence, if you were to be home right now, would you try to kill yourself? No. And access. Access could be open-ended, any access to any lethal means, and then closed-ended, specifically any access to firearms. Now, how you doing now? Liable?
Say yes.
Of course you are.
Did we ask about previous attempts? Or
Good job. What you have not yet addressed, even doing the safety assessment, is the full risk assessment for suicide, otherwise known as the SAD person scale. Right? These are the independent risk factors for suicide and violence, by the way. SAD persons. And at the end of this discussion, right, sex, age, depression, and other mental disorders. Persons include exactly what you just said, previous attempt, ethanol, other drugs, rational thinking loss, support system, either lack of a support system or recent loss within one support system, organized plan, no spouse, and systemic medical illness. Your patient has to hear two things now at this point. Number one, what your overall risk is. Is it imminent? Did they endorse an organized plan? Is it severe? More than 4 risk factors. Is it intermediate? 3 or 4. Or is it modest? 0 to 2. And that should inform what level of care you're going to recommend they receive that sertraline. Inpatient versus outpatient. In addition to all of that, you then need to review with the patient all the potential modifiable risk factors. I mean, if they're an old male and that confers 2 risk factors, there's nothing you're going to recommend to address that. But the modifiable risk factors better show up with your treatment plan, every single one of them, on your problem list. And for each of those modifiable risk factors, AKA problems, you better have a plan in place. You did all that. And your medical record documentation is consistent. The patient is only mild to moderate risk. And you did delineate 4 problems. And under each of those problems in your assessment and plan, you do have recommendations as to what you're doing. All there. Liable now? Sure. They are. Yep. One final reason why. Oh, by the way, this is standard of care. And despite the fact that 80% of people get their antidepressants prescribed by a non-psychiatrist, those individuals, those prescribers, are going to be held that same standard. And they're going to march me and my colleagues on the stand to testify to that. So when you choose a career outside of psychiatry, be very careful about what you're going to treat that is not within your training. Because you are liable here. For an outpatient psychiatrist, this is routine practice. Why are you still liable here? We mentioned informed consent, but you only mentioned part of the informed consent. You didn't mention all of the informed consent. Which part did you miss? We said risks and benefits.
Is it capacity?
So potentially, yes. If your mental status exam throws that into question. If your mental status exam says the patient is awake but is not alert and only oriented to self, 0 out of 3 registered, 0 out of 3 at 5 minutes, unable to spell world backwards, and has demonstrated an inability to name a pencil and a watch, boy, you better say something about capacity. But if the mental status exam findings don't suggest that it's inferred and you're safe. Because even though that might be a point of contention in court, your argument is going to be that there was no evidence of that individual being incapacitated, as demonstrated by your MSE findings, and that would stand. It's easy to convince 12 of course.
And he agreed to taking the medication? Like he said, yes, doc, I'll
Yeah.
take the medicine.
Okay.
Okay.
They consented. Were they truly informed? You're missing one other part of the informed consent. You just missed it.
Like how often to take?
Nope.
I was gonna say the same thing.
No.
Risks, benefits, and
Like explain the medication.
nope. Alternatives. Alternatives. A person cannot make an informed consent without knowing possible alternatives. And there is one here, and this now will draw back to our case, that is FDA approved for both bipolar as well as unipolar depression, major depressive disorder, that is better than sertraline and safer.
Is it ECT?
Yeah. Matter of fact, if this individual turns out to be bipolar, not only is it indicated, but almost the medical record, evidence-based medicine demonstrates that it's anti-suicidal. And you didn't even allow for that in the discussion. Instead, you prescribed them a medication as a black box warning of suicide. And now they completed a suicide. And you withheld from them information about a better modality that's safer, that is anti-suicidal. Were you practicing, doc? ECT. So when should this conversation come up? Well, the APA says at least 5 specific instances where ECT should be your first choice. That is, that ECT is the primary choice, primary indication. Now, most ECT referrals are the result of refractory depression. That's a secondary referral. The primary referrals include major depressive disorder with psychotic features, include major depressive disorder in pregnancy. That is, on your shelf exam, if either of those are in your clinical vignette, and the question stem asks, what is the best choice of therapy? If ECT is there, you pick it. Number 3 is catatonia. Number 4 is acute mania. Again, as our patient demonstrates. And the 5th one is patient preference. And that's the one that's going to really, really hang you in court. Because what patient wouldn't choose ECT when it has far less side effects of sertraline? Not only does it have absent suicidal thoughts in terms of a black box warning, but it's actually anti-suicidal. It's got a better efficacy, 50-50. 50%, it's 50% of patients in outpatient practice that receive the initial SSRI or antidepressant respond. ECT, 90%. So patient preference, who wouldn't prefer that? But you withheld it from your patient. And this is where your informed consent can come back and bite you, because you were an astute clinician and you actually documented a black box warning. You actually told your patient that they can kill themselves if they took the medication you were giving them, while withholding the one that's anti-suicide. The good news is that it's not going to even go to court. Right? There's no way any lawyer would allow you on that stand, or even just to go to court. The bad news is that you're going to have to settle, and you're going to spend the rest of your life filling out all those forms anytime you try to get hospital credentials. So again, be very careful if you choose to go into a field other than psychiatry and prescribe antidepressants. Again, it's at an 80% clip now. Questions?
Might be a stupid question, but why don't we just do ECT on all of the class patients, like first, instead of giving medications?
I don't know the answer to that. It's expensive, and not all insurances cover it. Most do, though. So, to answer your real question, just to rephrase it, for those people who have insurances that do cover it, why isn't it provided more often? And I think the answer, honestly, not trying to be mean, is ignorance. And it's not ignorance of the patients by any stretch. It's ignorance on the behalf of the prescribers. And the issue of psychiatry not providing the proper psychoeducation to the public. And we can see this because if you look at like a 10-mile radius, not even a 5-mile radius around an ECT center, the percentage of referrals for ECT are significantly larger than the 10-mile radius versus a 20-mile radius. So the more and more you remove yourself from one of those centers, Princeton Hospital, Jersey Shore University Medical Center, the less likely you are to get a referral to ECT. And it's growing ignorance. People just don't think of it because they're not practicing it, or they're not practicing or credentialed in a center that is using it. So I think that's evidence of it just being apathy on the field of, with regard to the field of psychiatry, and then ignorance among our colleagues, which of course is due to our apathy. Other questions?
If you're a non-psychiatrist provider and you just elect not to prescribe antidepressants for those like reasons, would you still be held liable if you commit suicide? Like if you just gave them a referral to see a psychiatrist or something instead?
It's a good question. If you let your patient know that you are not comfortable treating an illness for which you are not trained, and you establish that they are safe, they're not at imminent risk, and provide them follow-up, then you're not liable. I mean, I think if you really wanted to make this a tight case, you would even establish an appointment prior to their leaving their clinic visit with you, if you had those resources available. That would really seal it. That's real standard of care. Other questions? All right, we'll hit lunch now, come back in about a half an hour and talk about Donnie Darko.